Everyone, this is Julie. I'm going to do a quick review over Unit 6. This will probably be broken up into two, trauma, stress, and disassociation, and then elderly and neurocognitive will be in its own separate video. So when we start with trauma, we talked about what is trauma, and there really isn't an answer for this. There are so many different things that can unfortunately be included in it. Everything from violence in the family, sexual assault, racism, loss of a loved one, school violence, community violence. We looked earlier in the quarter, and we're talking about it again, of what are those 10 ACEs. We don't have to be able to memorize our 10 ACEs, but we just need to know that these are different things that occur in kids, and they have a profound impact on them physically, emotionally, psychologically as these children are growing. But also what everyone's number is when we consider ACEs are going to be dependent upon that child. We can see 1 in 6 adults experience 4 or more ACEs. And if we decrease ACEs, we can decrease 21 million cases of depression, 1.9 million cases of heart disease, and up to 2.5 million cases of obesity. So these are huge. Being able to mitigate these, being able to provide services and resources for children are extremely important. So one of the things we think about as nurses, not just in mental health care, but in every environment, is what is trauma-informed care. And there are 4 different components of trauma-informed care. We have to recognize, we have to realize, your book uses realize, the widespread impact of trauma, and that this is not an easy pathway to recovery. So we don't know who of our patients, of our coworkers, have experienced trauma. And we need to realize that it could be anyone around us who is kind of hiding this internally to them. We have to recognize the signs and symptoms of trauma within our clients, the different things that they're going within the family members of the patients we're treating, of the staff who are involved. We need to respond by integrating policies, procedures, knowledge into our practice, how we are working with patients, how we are communicating with them. All of it needs to be considered. And then we need to resist re-traumatizing the patient and the family. How are we communicating? We talked about the example in class. If I was about to go give someone a pap smear or do a suppository, I'm going to explain every single step, and I'm going to ask the patient's permission every single time my hand goes on them. This is my right hand. My right hand needs to go onto your upper leg right here. Is that okay? This is my left hand. My left hand needs to touch right here. Is that okay? And I'm going to explain to the patient, give them a lot of autonomy to make their own decisions in this. So when we talk about trauma disorders, we have 4. PTSD, we will look at PTSD in adults and children. Attachment disorders, we're going to talk about briefly, and acute stress and adjustment. So child abuse is kind of where we're going to start. Children will experience traumatic events, and they don't always have coping mechanisms to take care of themselves. Kids very often need to externally process events. They don't have the skill and the ability that the older adult does to process trauma. They don't always understand it. Kids are at a greater risk of developing physical illness and psychological problems as a result of their trauma. Neglect is our most common form of abuse within the family. So kind of not taking care of kids, leaving medications out on the client, not necessarily feeding them, having an unfit living environment. Neglect can be so many different things. Physical and sexual abuse, we tend to have an understanding with. Sexual abuse, it is not just participating, but it could be forcing a child to witness. And then kids who have experienced abuse are more at risk of abusing others. Kids, it is hard. They tend, especially like when we look at preschool kids, it's not always manifested in the same way when we look at PTSD as we would expect in an adult. They're not going to play as much. They'll have repetitive play that includes aspect of their trauma. They're withdrawing from their friends, having negative emotions, fear, guilt, anger, shame. After abuse, kids tend to blame themselves for what has happened, which complicates the entire picture. So we can see when we are talking about abuse, biological parents, father and mother, are at the highest risk of maltreating children. So when we look at those symptoms of PTSD kind of in general, we have a few things we have to consider. So exposure, actual or threatened death. It could be that we witness something. It does not have to be something that occurs to us. It could be very much that we are witnessing it. We saw something happen to someone else. We found a dead body on the side of the road. Um, Repeated extreme exposures, different things are going to have different impacts on it. So we have a few different types of symptom types. Intrusion, um, nightmares, flashbacks that come when we don't want them to occur. Persistence avoidance of stimuli. There may be a trigger, a certain smell, a certain sound, and we are avoiding that. Changes in mood, anger, depression, anxiety. And then alterations in arousal and reactivity. And it could be both hyperarousal or hypoarousal. Is this person always on alert? Are they always kind of like on standby, very like fidgety, or are they extremely withdrawn? So PTSD, I'm flipping buttons too fast. PTSD in children specifically. Exposure is the same as if we're talking about adults. Did they actually witness something or did something occur to them? It could be watching, if we talk about children, watching the mother be abused. If their parent is being abused or assaulted, that is exposure. It does not, the child could be safe. No one could be hurting the child, but they are witnessing that violence. Intrusion symptoms, again, with kids are a little different. They could still have those flashbacks. They could still have those recurrent dreams, the physiological reactions to triggers. However, in kids, we often see that reduction in play, and then we see that trauma that occurs in play. They're drawing pictures. That's kind of how they are grieving and processing. That is their response to the trauma. They will avoid things that remind them about it. They also tend to have somatic symptoms. Headaches, upset stomachs are much more common in kids. We will briefly talk about attachment theory. So attachment theory does have to go with Erikson. This is that trust versus mistrust. If that child does not learn as an infant, usually the first 8 months of life, when we're talking specifically about attachment theory, how to trust an adult, that will carry over into every aspect of their life throughout. It very much just continues. So what are some things that affect children? A chaotic home life. If they are unhoused, if they have parents who are doing substances, that can add or support whatever is happening. It can add more stress. If their parents are not modeling appropriate behaviors, if the parents are coping with stress by doing substances, that child is going to learn to cope with stress by doing substances. Cultural expectations. Sometimes kids are just caught culturally, you just got to suck it up. We don't talk about this. These are not things that exist within that specific culture. Again, that stable, nurturing environment versus a chaotic, non-nurturing. That kind of, again, goes back to Erikson and that attachment theory. Do the kids have an adult that they can turn to? Do they have a supportive teacher who they can go and talk to? Or is there no one and they kind of just trying to manage this on their own? And then again, those adverse childhood experiences and that ability to develop resilience. Resilience does not mean we are not affected by the things that happen to us, but it means we have the ability to bounce back. So when we are assessing children, we need to interview, observe, screen, and interact. I want to interview the child, the parent together, and then the child separately and the parent separately. We also can observe the child and play. How are they playing? What are they coloring? How are the parent and child interacting together? Multiple sources of information are great for children. We're going to assess for our PTSD type symptoms, nightmares, hallucinations, those intrusive thoughts, flashbacks. How are they playing? Are they pulling away from their friends? Are they cutting themselves, banging their head on the wall? Those kind of self-injurious behavior. There's a few different ways we can do. Developmental assessments are pretty important at this stage because it provides information about the child's maturational level and what we should be expecting from them. Interventions for children with PTSD. We want to establish a relationship. We want the child or adolescent to be able to talk to us. We want them to come to us when they need help. We have to use developmentally appropriate language and teaching tools. When we did our deep breathing, when we talked about coping skills, I might tell an adult to do square breathing, you know, or circle breathing. We have a few different types. Inhale 4, hold 4, exhale 4, hold 4, inhale 4. A kid's not going to understand that. So I would use my bunny breaths or talk about hot chocolate or birthday cakes to get them to do deep breathing. SSRIs are a great choice for pediatric patients. They have the least amount of side effects. However, we also need therapy. We have a few different types of therapy. EMDR is one. We could talk for hours about EMDR. At the simplest, it helps. We're using eye movement. We're doing tapping while we're kind of talking about the trauma to help desensitize. CBT, cognitive behavioral therapy, and then a trauma-focused CBT are, again, other really good options. We know that the child is better when they're safe, when their anxiety is decreased, when their emotions and behavior are appropriate for a children at that age level. We want the child to be meeting their developmental milestones. Did they stop meeting milestones and now they're kind of catching back up? And we always want children to seek out adults for help when needed. If we are talking about PTSD in adults, it honestly is extremely similar. We have the persistent re-experiencing, the dissociative reactions, the recurrent dreams, the physiologic reactions to triggers, and those involuntary memories, the flashbacks. We could talk about indirect exposure. We see something happen to someone else, and the trauma is happening to someone else. We are witnessing it. As first responders, we often have what is called secondary trauma, where we are taking on our patient's trauma, and it is hard for us. I think the statistic is somewhere about 55 to 90% of people will have at least one traumatic event in their lifetime. And how we all respond is going to be variable, so we can't always stick to something concrete. So when we look at our interventions for adults with PTSD, psychoeducation, that is actually a lot. I know at least in my clinical groups, when we talk about the groups that we're doing in clinical, how do we improve our self-care? How do we improve our coping? What are some relaxation techniques that we can use? Medications are going to be varied and great, again, depending on the patient. Usually they will be focused on antidepressants and anti-anxiety. SSRIs, SNRIs are some options. Clonidine can help with hyperarousal. Not on here, one we often see in this area is minipress, or prazosin is that kind of long name for it. It's an antihypertensive that when given at night helps decrease nightmares in patients with PTSD. Same as children, psychotherapy, cognitive behavioral therapy, a trauma-focused cognitive behavioral therapy, along with EMDR. Medications will mask and help with the symptoms, but it will not address the underlying cause. Our patient with trauma also needs therapy. Treatment is effective. Our patient recognizes that they have trauma. They're able to use new coping skills depending on what is going on with them. There is a decrease in flashbacks. There's a decrease in nightmares. They are sleeping better. They're meeting their roles. They're meeting their expectations. For, if they're a mom, they can take care of their kids. They can drive themselves to work. It could be varied. So acute stress disorder, we're going to think of almost like a PTSD light. This occurs right after a traumatic event. It occurs within that month of trauma. And these are the usual symptoms that we expect to see after some type of traumatic event. So if you were in a sudden car accident, and let's say it's a bad car accident, we don't just expect you to be okay with it. Headaches, maybe that amnesia, forgetting the event, irritability, nightmares, those are normal things that can occur. If the symptoms go away, and they only last for a few days within that first month, that is when it is acute stress disorder. If the symptoms persist and the symptoms are still happening 35, 45, 60 days later, right, that greater than 30-day mark, it becomes PTSD. So this is what happens first, right after that traumatic event. If we do not address it, it continues into PTSD. Now, adjustment disorder is a stressful event, not necessarily traumatic. So when we talk about acute stress disorder, Generally speaking, we're talking about something traumatic, car accident, rape, seeing someone get killed. Adjustment disorder is a stressful event. You have a new job, you move, you have a new child, you used to be working and now you're all of a sudden a stay-at-home mom. I mean, it could be great what it could be, not necessarily trauma. Um, it could be seen with depression, it could be seen with anxiety. And usually it's in 3 months of the onset of that stressor that we see these symptoms occur. Now we can see in criterion B, the distress is out of proportion to the severity or intensity of the stressor. We can also see that we have impairment in functioning. So one of the examples that we talked about in class, and if you have not seen it, I recommend you go watch it, is Riley from Inside Out. So this is kind of a Disney Pixar movie. Riley was a well-adjusted kid and her family moved. Once she moved, she struggled to make friends. She didn't enjoy the things she used to enjoy. She got agitated. Her emotions were all over the place, which are all completely different from her normal behavior. That is classic adjustment disorder. I'm going to flip through these videos. So we're kind of switching gears to our dissociative disorders. Dissociative disorders, we pair them with trauma because we can see they often occur after adverse experiences and trauma. There really are no clear-cut risk factors for dissociative disorders except having had a trauma. And disassociation at the simplest is a defense mechanism that is meant to protect us. So the example I give in class is dissociation as a defense mechanism. You are driving home from work. You are super stressed. You had a bad day. And all of a sudden you are home and you have no recollection of the drive home. That is disassociation. Disassociation can be a good thing. We tend to always, think symptoms, disorders are bad. However, we can see in this third bullet point, it can be a protective factor. If we have a child whose caregiver is abusing them, whose parent is abusing them, and they are able to disassociate, it allows them to kind of remain safe as they're psychologically as possible with that caregiver. So we have 3 types of disorders we're going to talk about: depersonalization and derealization, amnesia, and identity disorder. So depersonalization and derealization are distressing, but generally are short-lived. They can go away on their own. So depersonalization is that out-of-body experience. Something traumatic happens and we felt like we were watching it from above. Derealization, I feel like I'm floating. I feel like the environment around me is a fog. I feel like there is a veil between me and the outside world. Both of these can go away on its own without any treatment and usually occur right after or with that traumatic event. This is that vignette from your textbook. So dissociative amnesia is kind of just what it sounds like. It is a type of amnesia. We have this traumatic event and we cannot recall personal information. And usually that personal information is related to whatever the event was. So if we have someone and there was a shooting at school, they will tell you, I can't remember anything about what happened at school last week. If there was a car accident, they will not be able to remember anything about the car accident. It could be the entire event or it could be selective. We remember the car accident, but we don't remember seeing the body and the blood. If we had someone who passed away in their car accident, their brain is selectively remembering things. Dissociative fugue is a type of amnesia. Fugue, we're going to think about fugitive, right? They tend to run away. We have sudden travel and we cannot remember our autobiographical information. So in amnesia, we cannot remember the specifics of an event. In a dissociative fugue, we cannot remember who we are. Historically, if we look, it's a little bit harder in modern days. This individual would go and get a new family, a new home, and set up a new identity, a new life. Not on purpose, but just they can't remember. They don't know why. They just have forgotten who they are. They have a whole new identity. We watched this little clip. She's talking about how school is stressful. but she can't remember what happened at school on Tuesday. And the guy's like, nothing? Like, you don't remember what happened at school on Tuesday? She's like, no, nothing happened. We're going to assume in that dissociative amnesia example that something traumatic happened on Tuesday. She just can't remember it. We watched this little video about Hannah Up. She has disappeared multiple times. And they have one of the first times when she was in New York, people would see her walking around town, going about doing activities, showering, going into places. But when someone's like, Hannah, she's like, no, I'm not Hannah. Like, what are you talking about? And she had no idea that she was Hannah. And then all of a sudden they found her, weeks later. And she was like, she has what in her brain feels like 30 minutes, but it was actually 3 weeks that she was missing. So dissociative identity disorder is one of our more severe forms of dissociation. Our DSM calls it dissociative identity disorder. You know it as multiple personality disorder. And in our patient with multiple personality disorder, we have 2 or more distinct personalities. And each of those personalities are trying to take control of the other person. So each personality has their own identity, their own way of thinking about the world. I might have a 36-year-old male. However, inside, when we look at those alternate personalities, there is a 76-year-old woman, there's a 7-year-old boy, there's a 13-year-old girl, and each of those personalities are going to act like a 13-year-old boy, like a 7-year-old boy, depending on what happens. That host is not always aware of what is going on. They may have gaps in time. They could eventually understand what is happening, but it is different. Switching is that period of when we're going from one personality to another. It could be very dramatic, or we might not be able to notice it. It does often occur when we are stressed, so teaching this patient coping skills and relaxation techniques is always helpful, because if we can help our host kind of with their coping and anxiety, they may not switch as much. Our big risk factor for this is severe sexual, physical, or psychological trauma in childhood. And again, this is that protective factor. We talked and watched this little video about Jenny. She has a huge amount of different personalities. And we know from listening to her talk, Symphony is one of her personalities, and Symphony has to exist because Symphony has the ability to tell what Daddy did. She underwent and was exposed to severe physical and sexual trauma by her father. And those different personalities allowed Jenny to remain safe and protected. The big thing we're going to think about at the simplest when we look at our signs and symptoms, the patient's not going to respond to their name. I would be like, hey, Jenny, can you tell me your name and date of birth for meds? And all of a sudden someone would be like, it's not Jenny, I'm Muscles. And we realized we were talking to Muscles, not Jenny. Skip the video. So risk factors, again, severe childhood sexual, physical, emotional abuse. It is protective. It is the most primitive defense mechanisms. It can happen to anyone, male, female, age does not. There is no primary thing I can tell you, look out for this type of person. It is often comorbid with many other conditions, and a lot of times they can just go away on their own, but we also do need a lot of education about it. When we are assessing, we have a few things to focus on: the history of trauma, what's happened, adverse childhood experiences, head injury. Memory and orientation is a good one because this patient may not know who they are. And suicide and self-harm will always be a consideration. When we are planning treatment, we have a few different phases. In the beginning, we just want to look at safety and symptom reduction, and then we want to try to work through in that phase 2 past trauma. For the most part, as a nurse, we're going to be focused on that phase 1, safety and stabilization. The therapist, psychologist, they're going to be working with the patient usually through phase 2 and 3, where we're working through that trauma. When it talks about identity integration, if we're talking about dissociative identity disorder, the goal of treatment is to take that multiple identities and fuse them back into one. So no offense to Muscles or Symphony, we would want Jenny to have one personality. When we look at psychoeducation, we do have to talk to the patients about the diagnosis. And it's very hard. We almost have to normalize this, let them know dissociation, right, is a primitive defense mechanism. It is protective. It does not mean that there's anything wrong with you. Um, Coping skills, stress management, and honestly, always with trauma that tainted or deserved it. Especially if we're looking at kids, they tend to focus on themselves and why they are having it as something that they did wrong. There are really, again, no pharmacological treatments for PTSD. We're looking a lot at the symptoms and how we can treat that. Let's skip through some of these questions that we did and then go to somatic symptom disorders. So a somatic symptom is a physical symptom: headaches, upset stomach, chest pain, back pain, insomnia that can occur as a result of a psychiatric condition. We have 4 different types of somatic symptoms that we are going to talk about. So our first somatic symptom disorder, this is an individual who is focusing on a physical symptom to the point of excessive concern or preoccupation. Their suffering is authentic. They will have a high level of functional impairment. So if this patient is coming in and complaining of a headache, they truly are having a headache. If they're complaining of back pain, truly are having back pain. They will be seeking out help, but the help, right, if they're coming with migraines and I'm giving them meds for migraines, it is not helping the migraine because it is not a physical cause, and the meds are for physical causes. So this patient will often have multiple medical complaints but have no findings. They will have been seen, and we always have to assess who are they seeing, because they will also often go from doctor to doctor to doctor to try to find an underlying cause. Even if we have a patient who has a history of a somatic symptom disorder, we know they have a somatic symptom disorder, we always have to assess and investigate these physical complaints. I honestly have no idea how many times I have called an ambulance for a little old man with chest pain, and I'm 99% positive that the chest pain is caused by anxiety, but we are still going to send them out and get that chest pain investigated every single time, because heaven, that one time that it happens, I don't want it to kind of be on me. Patients do become frustrated again because nothing is helping them. We watched this video. Matthew, the little boy who was in it, was kind of a great example. He was passing out, and his principal's like, look, without any kind of medical information, it is not safe for you to be in school. And the principal told him he could not go to school until they figured it out. And Matthew was going to doctors and he was having tests, and it wasn't until he was hooked up to monitors one day and the tech was making small talk and the tech was like, hey, how's school going? And Matthew suddenly passed out. That tells us and kind of lets us know, hey, look, there's probably something else going on with Matthew. It is not just passing out. Why did he pass out when we talked about school? What is going on at school? Illness anxiety disorder is the second one we talked about. This, again, is similar to hypochondriasis. It used to be known as a hypochondriac. However, diagnosing someone with illness anxiety disorder sounds much nicer than diagnosing someone as a hypochondriac. So this individual is extremely worried and scared about the possibility of having a disease. Now, in our somatic symptom disorder or somatoform disorder, our patient is complaining of a headache, and they truly do have a headache. In illness anxiety disorder, it is a toss-up. Our patient may have a headache, and it may truly be a benign headache, but to them, it is a brain tumor. They may be excessively tired, and maybe they're excessively tired from stress, but they are so focused on the fact that they are tired and they must have cancer. There has to be something wrong with them. And they tend to obsess about these symptoms or these potential symptoms. Some individuals with illness anxiety disorder are going to go to all of the doctors. They will go from doctor to doctor to doctor looking for someone to give them the diagnosis that they know that they have. Others will avoid the doctor. I am not going to go to the doctor because I know if I go to the doctor and tell him about my migraine, he is going to tell me I have a brain tumor, and I just don't want to hear about it. So they stay at home and think that they have a brain tumor versus going to the doctor. Others excessively go to the doctor. Social media, the internet has increased these fears because it is so easy to just look up and see what is going on, and it always tells you the worst case scenario. We watched the little clip. She's like, but there is a lump. It is inside of me. I know it is cancer. They have run tests. They have run imaging. They have done lab work. The doctor cannot find any reason for these things to be occurring. Um, Conversion disorder is one of our last in this section, and then we're going to kind of jump. The patient has neurological symptoms. So they see something and all it's traumatic, and all of a sudden they go blind. They hear something traumatic, and all of a sudden they go deaf. Um, they watch someone else get hurt, and all of a sudden they can't use their arms or their legs. They have paralysis. Oftentimes, one of the things we see when we are talking about conversion disorder is something called labellin difference. Basically, we have an extreme symptom, paralysis, blindness, that comes on suddenly. However, they have a lack of emotional concern. Dramatic symptom, minor concern. We do have some risk factors for this one specifically. Low socioeconomic status, rural setting, history of child sexual abuse is common. But regardless of any of those, if this happens, we have to rule out physical causes. If your patient is telling you they are paralyzed and it started suddenly, they truly are paralyzed. If they're telling you they are blind, if they're telling you they are deaf, it truly is like that symptom is there. We watched this little video. Her daughter was abused, and she's basically is like, hey, I didn't do it. A little bit of amnesia going on, but she can't use her right hand, and she is right-handed. And she's like, yeah, all of a sudden, like my right hand, it just went like limp and went numb. I can't use it. And she was very unconcerned about the fact that she's unable to use her hand. So in assessing our patients with somatic symptom disorders, conversion disorder, illness, anxiety disorder, we always have to do a thorough physical assessment. We have to rule out physiological causes, but it's hard because we don't want to do unnecessary tests or procedures. The base assessment, new onset, new nature, characteristics, duration, psychosocial history is important. We have to look at our patient's ability to kind of meet their own needs. And we do have to remember that these are not, our true somatic symptoms are not under the patient's control. These are involuntary symptoms. Secondary gain, we're going to kind of talk about separately. Culture, spirituality, religion can come into play. If we are less likely to speak up and talk about what is going on that is stressing us, we are more likely to have a somatic symptom. When we look at kids and that I don't want to go to school because my stomach hurts, it kind of all plays and kind of goes into play. So if we have a kid who is constantly having stomach aches and pain and nausea and vomiting, what's going on at school that they don't want to go to school? Are they being bullied? Is there some type of traumatic event that has happened at school? We always want to develop a therapeutic relationship, and we have to be empathetic. Again, if these patients are coming in complaining of pain, we can't just brush them off. We have to understand that the pain is truly there. We need to talk about the feelings and emotions. We do have to look at physical symptoms. We definitely always have to look at physical symptoms. However, we also have to look at feelings and emotions. And we want to try to make connections between, the upset stomach and the stress and the worry. Coping skills, again, teaching is great. Meds are kind of iffy. There are some that are beneficial, but there is no specific medication for somatic symptom disorder. It's basically going to be treating the symptoms that the patient is having. So when we look at factitious disorder imposed on self, this is what we previously have called Munchausen's. This is someone who's faking it. They are doing something, whether they are pretending or doing something to make themselves sick in order to kind of be a patient, right? Because when we're sick, we get out of work, people clean our house. I don't have to deal with my kids. There's GoFundMe's for people who are sick, and we are doing things to fabricate our symptoms. So in one of the examples I talk about in class, Insulin is available over the counter at Walmart. So do we have someone who's coming in randomly with hypoglycemia and they're like, I don't know why this is happening. They don't have diabetes. Their blood sugar tends to be stable, but they are self-dosing themselves with insulin, even though they don't have diabetes, to present as sick. And that's kind of where that risk of injury comes in. If they're doing something to fake the symptoms, could they accidentally hurt or kill themselves? Again, this is compulsive. They will do everything they can to conceal it. They will be deceptive. They will go to lots of doctors. They're going to ask for help. We're going to run tests, and they're like, but I need help. This is still happening. The tests show that nothing is wrong, and they're basically just saying, hey, they're happening. In the previous somatic symptom disorders we have talked about, the symptoms were involuntary. But in factitious disorder, the symptoms are voluntary. The patient is causing the symptom, and they will doctor shop. Now, our other version of this is factitious disorder imposed on another. So this is our old Munchausen's by proxy, and we can see right here we have Dee Dee Blanchard and Gypsy Rose Blanchard. So Dee Dee Blanchard is the one who has the disorder. It is the caregiver. And this is when a caregiver deliberately falsifies an illness in someone they are taking care of. Oftentimes we see this as child abuse in young children. Generally by 5 or 6, the kid gets smart enough and it tends to stop. However, that caregiver gets that secondary gain. They get the attention from the child being sick. Gypsy and Dee Dee Blanchard, I know it's an extreme example because it continued on until Gypsy was in her 20s. But Dee Dee was a healthcare worker. She was a CNA, so she had a little bit of knowledge about the healthcare system. And if the doctor didn't tell her something she liked, if the doctor started to question it, she'd go find another doctor. Gypsy had feeding tubes and muscle biopsies and seizure disorders and extreme allergies where she was being given epinephrine EpiPens for no reason. She had so many different medical procedures that were unnecessary. This is abuse and we have to report it, but we do have to be cautious. We can't just confront the parent. We can't just be like, you have Munchausen's, like you're abusing this child. Because if we do that in clinic without any concrete evidence, that mother is going to flee, right? She took Dee Dee and freaking upped her and moved across the closet. Munchausen's by proxy is that big official name. So malingering is one of the things we see related to factitious disorder, and that is that conscious fabrication of symptoms. This is the person we talked kind of about, like the VA healthcare system. You get paid for being sick in the VA healthcare, like as a VA patient. So most patients in the VA don't get any better. They're going to want to be sicker because the sicker you are, the more money the VA is going to give you. So that fabricating, exaggerating our symptoms is malingering, and that secondary gain is what you are getting from it. So if I get rear-ended by a Amazon truck and all of a sudden I'm like curled up in a ball, like, oh my gosh, I can't move, my back hurts, I'm going to be in pain forever, even if I'm not really hurting. That exaggeration of that back pain is malingering. The secondary gain, I want the money that Amazon can give me, right? Amazon's got billions. They are going to pay me for my illness. We got our Gypsy Rose pictures. I do want to talk about, not this one. Find my mouse. The next question. So once we have an individual who's been identified as having a somatic symptom disorder, a psychiatric consult is initiated when new physical symptoms arise. Y'all kind of went back and forth on class with this one, but the answer is false. If we have someone who we know has a somatic symptom disorder and all of a sudden, right, maybe they're always coming and complaining of migraines and that was their somatic symptom, and now they're coming in and complaining of like an upset stomach, IBS type symptoms. We can't just be like, psych. We have to investigate the physical symptoms. That is the end of this section. I'm going to break these up into some videos so they're not too long. But if you have any questions, please reach out and let me know.